Welcome back, everyone, to the deep dive.
Great to be here.
Today, we're going to tackle Chancroid. It's an STI.
Yep.
And our mission really is just to pull out the key stuff you need to know, especially for revision. We're using our Chancroid overview and management notes.
Exactly. High yield focused. Let's get into it.
Okay, so let's start right at the top.
Right.
What exactly is Chancroid? Define it for us.
Sure. So Chancroid is a sexually transmitted infection. It's caused by a bacterium called Haemophilus ducreyi.
Haemophilus ducreyi. Okay.
And the real defining feature, painful ulcers, really painful sores, usually on the genitals or, wherever there's been sexual contact.
Painful is the key word there, then.
Definitely. And it tends to be more common in certain parts of the world, places where STIs are generally more prevalent and maybe healthcare access isn't as strong.
Right.
Oh, and actually, a little memory hook for you think ducreyi, causing those painful D.U.lcerous lesions.
Cray D.U.lcerous. Okay, I like that. So that bacterium, Haemophilus ducreyi, how does it actually spread?
Well, it's pretty much what you'd expect through sexual contact.
Yeah.
Vaginal, anal, even oral sex.
Okay.
The bacteria basically need a way in, so they enter through tiny, tiny breaks in the skin or mucous membranes during sex.
Ah, so little microabrasions we might not even notice.
Exactly. And once it's in, it's quite contagious through that sexual activity.
Got it. Who's particularly at risk then?
Well, the usual factors for STIs, really. Unprotected sex, especially with multiple partners.
Makes sense.
Having a history of other STIs puts you at higher risk, too.
Yeah.
Also, being involved in sex work or having contact with sex workers.
Right.
And like I mentioned, geography plays a part, living in or traveling to areas where Chancroid is more common.
Okay. So the bacteria get in through those tiny breaks. What's happening inside the body then to cause those ulcers?
So once Haemophilus ducreyi gets established, it starts damaging the tissue directly. That's what leads to the ulcer forming.
Right, the actual sore.
Yeah. And the body reacts, obviously. You get an inflammatory response, swelling, more ulceration. It's a bit of a vicious cycle locally.
Yeah. And these ulcers, they're infectious themselves.
Yes, absolutely. The fluid or pus in them contains the bacteria.
Yeah.
And, importantly, having these open sores makes it much easier to transmit other STIs.
Ah, like HIV.
Exactly like HIV. That's a really significant consequence. Having Chancroid increases your risk of getting or transmitting HIV.
Okay, that's crucial. Now, if someone presents with genital ulcers, it's not always Chancroid, right? What else might be on the list?
Good point. Yeah, differential diagnosis is important. We need to think about syphilis. Primary syphilis can cause ulcers, though typically painless.
Okay, painless for syphilis, painful for Chancroid. Big clue.
Generally, yes. Also, genital herpes. Very common, causes painful blisters or ulcers. And another one is LGV, lymphogranuloma venereum.
Right. So how do you tell them apart for sure?
Lab tests are really essential. PCR testing on a swab from the ulcer is great for detecting the Haemophilus ducreyi DNA directly. That's often the preferred method.
PCR, okay.
We also need to consider the whole picture. The patient's sexual history, what the ulcers actually look like on examination, and the local epidemiology, what diseases are common in that area.
Makes sense. You mentioned geography earlier. How common is it in, say, the UK?
It's actually relatively rare here in the UK. It's seen more often in certain regions of Africa, Asia, Latin America, the Caribbean, places sometimes with less robust sexual health infrastructure.
Got it. So let's paint a picture of the clinical presentation. What are the absolute classic signs someone might come in with?
The number one sign, the hallmark, is one or more painful genital ulcers.
Painful again.
Yes. And they often have a specific look, sharply designed edges, but they might look a bit ragged or undermined, like the edges eroding away underneath.
Undermined edges, okay.
And another really key sign is painful swelling of the lymph nodes in the groin, sometimes called buboes.
Buboes.
Right.
Right. And the ulcers themselves. Any other features?
Yeah, they might sort of merge together to form larger ulcers. The base often looks necrotic, dead tissue, maybe covered with a gray or yellowish-gray material. And some people might feel generally unwell, too, maybe a fever or just malaise.
Okay. So clinical picture plus the PCR test seems key for diagnosis. What's the full investigation process?
It starts with that clinical evaluation, looking carefully at the ulcers and checking the lymph nodes. Then, ideally, PCR from an ulcer swab or aspirate.
Right.
Culture is possible, too, taking a sample from the ulcer and trying to grow the bacteria. But H. ducreyi can be tricky to grow in the lab.
Ah, so PCR is more reliable.
Often, yes. And importantly, we'd usually do tests for other STIs at the same time, syphilis HIV, herpes, because co-infections can happen, or it might turn out to be one of those instead.
Right, cover all bases. So once you've diagnosed chancroid, how do you treat it?
Thankfully, it's treatable with antibiotics. The main goal is killing the Haemophilus ducreyi bacteria.
What are the go-to antibiotics?
First line is usually a single dose of either azithromycin orally or ceftriaxone as an injection.
Single dose. That's convenient.
It is, yeah. Helps with compliance. If those aren't suitable, maybe due to allergies or treatment failure, alternatives include courses of erythromycin or ciprofloxacin.
Okay. And anything else besides antibiotics?
Supportive care helps. So pain relief, obviously, since they're painful ulcers, and sometimes warm saline compresses can soothe the area.
And what about partners?
Absolute crucial.
Huh.
Part of management is public health, educating about safe sex, STI prevention, and definitely evaluating and treating the sexual partners of the person diagnosed. Otherwise, it just keeps circulating.
Right. Stops the cycle. What's the outlook like with treatment? And conversely, what happens if it's left untreated?
With prompt antibiotics, the prognosis is generally very good. Chancroid is usually cured, the ulcers heal up, often without much scarring.
That's good news.
But if it's not treated, complications can occur. Those swollen groin lymph nodes, the buboes, can actually develop into large, painful abscesses that might need draining. Yeah, and we have to keep stressing that increased risk untreated chancroid makes transmitting other STIs, especially HIV, much easier. So early diagnosis and treatment are really key.
So the big takeaway is, chancroid is treatable, often quite simply, but you need to catch it and manage it quickly.
Exactly that. Prompt diagnosis, effective treatment for the individual and their partners, it's vital for their health and for, wider public health too.
It really highlights how interconnected these infections are.
It does. It underscores the need for comprehensive sexual health approaches, testing, prevention, education, the whole package.
Okay, great overview. And just to drum it in one last time, that memory aid.
Yep, think ducreyi for the bacteria causing those characteristic D.U.lcerous sores.
Perfect. And for everyone listening who wants to dive even deeper or use this for revision, definitely check out pastthemsra.com and our free resources over at freemsra.com.
Absolutely. Great resources there.
Thanks so much for breaking that down for us.
My pleasure.